Good morning, good evening, and good afternoon, depending on where you are in the world joining us today. My name is Stephanie Sassman. I'm the portfolio leader of women's health at Roche and Genentech, and thank you for joining our live virtual event about innovations in women-centric care and how we can empower women's health. Men for too long have been the default human, and this has led to women's issues being overlooked and left behind. And as a result, it doesn't matter where a woman lives, we face inequities with regard to our treatment, care, and access to healthcare. And it's time that we embrace the unique biological differences every cell has a sex between men and women so that we can truly understand women's health and address their needs with tailored solutions. And we also must tackle as well the cultural and societal barriers that stand in the way of women getting the care that they deserve. And it's really on all of us to take action and shine a spotlight on the healthcare needs of women and reimagine healthcare with women in mind. And so today I'm really excited that we're going to be exploring this topic with this focus on innovation in research and development, patient advocacy and action, data and digital health innovation, as well as care delivery. And we'll have keynote speakers, including Michael Anakin, the CEO of McGee Women's Research Institute, Dr. Mahima Ashok, the Senior Director of Health Data Strategy and Product Outcomes Measurement of Blue Shield of California, and Mariam Mutebe, Dr. Mariam Mutebe, breast surgical oncologist from Kenya. And of course, just a note, we also had a patient speaker, Indira Oropesa, who's the president and founder of Con El de Leukemia. And unfortunately, for personal reasons, Indira is unable to join us today. She will be participating in the write-up of this event, and we will be able to call out questions to her. Of course, today is not only about listening and being inspired by our speakers, but it's also about the discussion with you and the audience. And so we invite all of you to take part in the discussion, submit your questions using the Q&A button in the bottom of your screen. And I'm going to do my best to ask as many of your questions as possible. And you can also rank the questions that you see from others, so we can try to make sure that we address the most popular questions. So please upvote. And unanswered questions are going to be stored, and where possible, in the write-up article that we do on healthcare transformers. They're going to answer as many of your questions as we can, and you'll receive an email from us announcing these publications. And so with that regard, I am going to hand it off to our speakers to give their perspectives on the importance of women-centric healthcare, starting with Michael Anakin, the CEO of McGee Women's Research Institute. Michael.
Thanks, Stephanie. So I would like to point out that women's health as a field has only been around since 1993. That's roughly 30 years of research and information that we have on women's health. It's important that we understand that there's a significant amount of catch-up necessary in order for women's health to have the same understanding and data-supported, evidence-based, outcomes-based support that men's health has. It's funny, even 30 years later, when we talk about women's health and the amount of investment that's made in women's health, for a population that makes up 51% of our current population and gives birth to 100% of our future population, we as a country, the United States, only invests 13 cents on every research dollar into women's health-based initiatives. And if you take that global investment, the number goes down from there. So it's critically important that we re-emphasize the investment necessary in women's health to be able to achieve outcomes that we would think would move the needle. It's also important to understand that we're coming into a time when women's health is getting a spotlight, and it's well-deserved, and it's a little bit probably late. If you think about the 30 years of history that we have in women's health research, it takes 17 years on average for something to go from the bench to the bedside. So currently, in the medical books, and what we're teaching our students, there's not a whole lot of cycles of women's health-based knowledge being printed in those medical books. So it's important to take the opportunity during this time when we've increased the focus to really make some headway when it comes to investment in infrastructure and support for our women's health-based initiatives going forward. We have significant data that would suggest that 64% of the time when sex is not taken into account as a biological variable, in other words, when we treat the disease and not the person, women have worse outcomes than men. That's not good enough when it comes to a healthcare system this advanced. We've got to do a better job. And we can't have personalized medicine moving forward if we don't start with a better understanding of the sex differences. So I hope your talk today leads you to develop new and innovative ways to put women's health at the forefront of your conversations. Thank you.
Thank you, Michael. And next, I would like to pass it to Dr. Mahima Ashok. And just to note, thank you for those that have started putting their questions into the Q&A. Please continue to put questions into the Q&A and upvote.
Thank you so much, Stephanie. Hi, everyone. It's a pleasure to be with you all today. I'm looking forward to a robust discussion. So my experiences and interests lie at the intersection of technology, product, and value-based care. And I have a passion for women's health in particular. I'm going to tell you a little bit about how I grew up and contextualize this in the framework of this discussion today. So I grew up in a small town in southern India, and I lived with my parents and my grandparents. And my grandfather was an eminent psychiatrist, and his clinic was a part of our house. It was at the side of our house. And as I was growing up, I would see men and women from the big cities, from villages, pulling up outside our house to enter the waiting room to see my grandfather. I also remember as a child, my grandfather telling me that in order to truly enable people to seek the care that they need, you have to make it easier for them to do so. And one of the things he would do was accept grains and produce as payments when people from villages, farmers, could not afford his care. And what he was really doing was removing barriers to care. He was enabling more people, particularly women, who did not have income to come and see a physician for their mental health care. And this concept of removing barriers and breaking the traditional molds of the system to eliminate barriers and disparities in care is something that remains incredibly important today. From a women's health perspective, we are at a point where there is so much data and so much technological advancement, and it's really upon all of us to transform the system that is defining the data, generating the data, aggregating and disaggregating the data, and using the data, as well as ensuring that emerging tech is inclusive of women's needs. And this really begins with broadening the description of what women's health is. And for a very long time, women's health has been reproductive health. And yes, that's true. Women's health is reproductive health, but it is not only reproductive health, it is also the numerous disease conditions in which sex plays a major part in both the development and the progression of disease. And then taking that data and technology lens, what are the steps that we have to take in order to ensure that women are represented in the data, that women's needs are factored into research and development, and ultimately that women are seen in clinical care and are delivered the kind of care that they truly need in that space. Additionally, there's also a move now in the health system to value-based care, which is really about pivoting on better outcomes, lower costs, and increased accountability. And to truly have a successful value-based care model, you have to be able to define value for everyone in the system, including women. And this means that we have updated information on the impact of sex on clinical outcomes, as we talked about, and that it is prevalent. There's also an increased and deeper focus on the kinds of data we collect, on how that data is collected, and how we fix the gaps in data by facilitating what Michael was talking about, which is really the generation and use of sex disaggregated data, so we understand what women need and how they need it. It also means focusing on the generation, on the prevention of diseases and prevention to improve outcomes for women. And from a technology lens, it means that venture capital firms start funding and continue funding companies that are finding new ways to collect data from women and building learning systems that can use data to drive change. So women's health is truly complex. How we define it is important. There's diversity and intersectionality within women's health, and there's also data bias. But there's incredible potential in this current moment about the future of data in this space, about the future of women's health. And I hope that we all leave this webinar thinking about how in each of our spaces we can do more to further the field. Stephanie?
Thank you, Mahima. And now I'm going to pass to Dr. Mariam Matebe, breast surgical oncologist in Kenya. Mariam, thank you for joining.
All right. Thank you so much, Stephanie, and really looking forward to a great conversation. I like to say I'm a breast cancer surgeon by day and a health systems researcher by night, and with my focus on really understanding barriers to access for women who have cancers and designing interventions that kind of talk to those barriers. And so in my role as the president of the African Organization for Research and Training in Cancer, and through different work that we've done with different commissions, most recently the Lancet Commission on Women, Power and Cancer, and looking at the recently released Commission on Breast Cancer, it's looking at what is going on with our patients as relates to the cancer space. And what we do know is that, as Michael and Mahima have outlined, there is a disproportionate burden of disease that affects women and poorer outcomes. We do know that by 2020, we had about 9.2 women who were diagnosed with cancer and about a little over 4 million women dying of cancer, but then they comprised almost half of the new cases diagnosed, half the new patients diagnosed with cancers. And I think what should be of concern, and we're thinking about why women's health, it's really thinking through, we have about, out of the 3 million patients who are living with cancer or newly diagnosed each year under 50, we do know that 2 out of 3 of those are women. And so there really is a drive to sort of think through how do we start to build systems and think through measures that help to, again, definitely try and see how we can ensure that we are saving our women during the most productive years of their lives, so to speak. Now, my experience across Africa, and I've had the benefit of working in different regions and liaising with colleagues across the continent, what we're seeing generally is that for many patients, not only are our patients diagnosed, they tend to be much younger, 10 to 15 years younger than their counterparts in the West, and tend to be diagnosed with more advanced disease. And not only are they diagnosed with more advanced disease, they frequently do not complete their care. And if we do a deeper dive into the reasons behind this, we see a constellation of factors that Michael and Mahima have also tried to outline. The fact that patients have to pay out of pocket, frequently resulting in financial toxicity and catastrophic health expenditure. The fact that the health system barriers that exist, and again, trying to think through this conversation today, how to mitigate them. What we do know is, for instance, in sub-Saharan Africa, patients on average will see 4 to 6 healthcare providers before definitive diagnosis of their cancer is made, really begging the need to really look critically about how do we enable and empower and amplify the role of healthcare providers to actually facilitate timely referrals of patients. And then looking at one of the things that Stephanie actually mentioned, the social cultural barriers that exist around cancer care. We sometimes say, telling a woman in Africa that you have, say, breast cancer, for instance, is not necessarily you have cancer. It's you could lose your source of livelihood. you could lose your family. So it's really a more nuanced discussion. And I think it's really that the point of the conversation today is how do we stop these silos? As you said, women's health traditionally represented that broad sort of reproductive health conundrum, and where we've seen a sort of vertical approach to care, where we've seen patients who are, for instance, living with HIV and constantly, engaging with the health system on a monthly basis, actually getting diagnosed with stage 4 cervical cancers, for instance. So it really begs us to take a step back and think through how do we then start to build that model around patient-centric care? How do we ensure that our women and indeed all our populations are adequately represented in both the care we provide, both the data that is provided, and of course the funding that actually helps to resolve some of these barriers and disparities. For instance, we know that in many parts of the world, and this was interesting to figure out, irrespective of where we are, geographical barriers, women have less access to knowledge around their health-seeking behavior and in their health decision-making. And not only, irrespective of where you were, whether it was an upper middle income country or a lower middle income country, we still noted that up to a third of women spent almost 30% of their annual household income on cancer-related costs. That's in upper middle, that's in upper or middle income countries, but all the way up to 160% of their annual income in low and middle income countries. And so it's really embracing, as Mahima is saying, the concept around value-based care, and how do we ensure, as we sometimes say in Africa, poor people cannot afford poor care. So it's how do we really bring to the table cost-effective quality care that's not going to break the bank. Thank you.
Thank you, Mariam. I see that we're starting to get some questions. I would love to see more questions come in. I think we've heard, some really important points about the data gap. I think we've heard about the barriers that need to be removed. We've heard about some of the inequities that might exist regionally for women, where the barriers are even harder, based off of lack of healthcare systems, or based off of taboos and social determinants. But let's move on to a couple of the questions that have come in so far, but please submit your questions. But I'm going to direct this first one to you, Mariam. And it's really, what role does integrative medicine play? And can you identify some of the innovative integrative solutions that have been applied in approaching women's health?
Sure. And I think one of the first steps that we do need to do, even in terms of thinking about approaches to care, is really appreciating what is the ecosystem that is around the patient. Sometimes we think about treating the patient. It's acknowledging what the social cultural context is and thinking about how do you address the needs. And we, for instance, in Africa, we always say our strength is community, but sometimes we have what we call collectivism, where sometimes decisions are made by the community, and it's a bit of a double-edged sword, because in that sense, if the patient is losing agency over their own decision making. For instance, I'll give you an example. I have, as a breast surgeon, I sometimes see patients who have to make a decision between, say, breast conservation or having a mastectomy, and give the patient options and tell her to go home. So come back and there's a clan gathering, and the senior elder is saying, we have decided, and we're like, who's we? Right? And so, but sort of talking to the patient, she says, well, I would like to have this option, but they're the ones paying the bills. And so looking at what does that mean in terms of decision making for patients? How do we enhance or support agency? The other thing is there's still a lot of stigma in many parts of the world around the cancer diagnosis. And so women would prefer to sort of hide away until, or not reveal their cancer diagnosis until, it's maybe gotten to an advanced stage just because of the fears and the stigma that is concerned with cancer. So in thinking through how do we solve, because healing is not just, sorting out the cancer, it's how do you contextualize this to the patient. If they're hearing out in the community, they're getting ostracized because they're of disreputable or sexual indiscretion because they've gotten a gynecological cancer, for instance. It's really thinking through how do we then shift narratives. And one of the integrative solutions is really looking at how do we incorporate some of the, one would say, and again, as a clinician, I always see my colleagues rolling their eyes, but the reality is quite a number of our patients did a study on use of alternative therapies. We noticed that up to anywhere between 60 to 70% of our patients have actually used alternative therapies. And again, unless we normalize that conversation and bring it into the treatment algorithm and start to rather than looking at people as competition, looking at how do we work together. And so part of the approaches have been, one, actually integrating traditional healers and using them as change agents to facilitate referrals, prompt referrals to hospitals and things. And that has also helped in terms of, one, you're appointing what people would consider key opinion leaders in their setting, and integrating them into the health system and using them to facilitate both prompt referral and identification of things that may be beyond their ability to treat. And so it's really thinking through how do we incorporate not just the physical, but also, as Mahima would probably say, the physical, the psychological aspects of care. How do we deal with the stigma? And those are some of the strategies that have been used in terms of trying to reduce the stigma, but also trying to facilitate prompt access, identification, and referral to the system.
Great, thank you, Mary. Michael, I know that this is also something that that is really close to close to something that you're really passionate about. Do you want to add any comments about that?
Yeah, well, I mean, I think that integrative medicine is important to understand, and we're, as a health system, and by health system, I mean the health system at large across the country is understanding the importance of integrating that type of care into modern what we call personalized medicine, right? And it's more prevalent in some parts of the world than others. It's more prevalent in some regions of the United States than others. But I think all of us as a health system are trying to integrate these new methodologies that have a community-based component to it. Because what we're finding is that when medical interventions are combined with community-based interventions, they actually have better outcomes. They have better outcomes, people do better. And ultimately, none of us got into this for the papers that we published. We all got into this to make people's lives better. And so when our patients are doing better, everybody wins. And so these integrative approaches are definitely a part of the future of medicine as we see it. And I look for them to continue to expand.
Great, thank you, Michael. I think there's another question that really builds on this, and I want to direct it also to Mahima, because you talked a lot about the value-based care and the fact that value-based care also means that it needs to consider the value to the patient, and in this case, the value to women. And so what are some of the actions that you see that health systems could take today to ensure that women are receiving patient-centric, or in this case, women-centric care?
Yeah, that's a great question. So in order to ensure that health systems are able to take care of women, we first have to make sure that they can understand women. And that starts with improving our education models. And when we think about women's health and being able to target women's health more effectively, I like to think about it in terms of 3 pillars. So representation, education, and access. So representation is making sure that within health systems, there is access to data that is representative of the women and the communities that they're treating. And if that means that we're going out into those communities to gather data and gather information, that's what health systems need to do. And that's also a space for technology startups to start coming in, ensuring that they're in those communities, gathering that data and feeding it back into the health systems. The second piece of this is really around education, and that is actually one step removed from the health system, making sure that medical education includes a sex differentiated focus. And what that means is understanding the differences between how diseases develop and progress between men and women, the different stigmas that women face, as Miriam has talked about today, and making sure that when women are seeking care within a health system, that they are seen for who they truly are, and they're given care that understands the different cultural and social contexts that they may be undergoing. The third part of this is access. And one of the interesting things that we've seen is when you look at claims data, from a payer perspective, claims data is actually very rich data, even though it's focused more on a financial side. But what we have seen in research is that the number of documented diagnoses for women is far less than the true diagnoses that we know exist for women. And what this means is that there is not enough documentation and understanding of diagnosis in that clinical encounter. So what do we need to change broadly as a health system? And that includes the payer side too. What do we need to change? We need to have better data that is more representative, and we need to have data that is disaggregated. And Stephanie, you touched upon this, that men have been sort of the default human for a very, very long time. And that leads to research in cancer care, in heart disease, in diabetes, being focused on men as the default human, where these diseases manifest and progress differently for women. Now, as we start seeing an increased attention to women's health and the disaggregation based on sex, I think we're going to start seeing an increased uptick in terms of positive outcomes, and that ties back to that value-based care journey.
Thanks, Mahima. I completely agree. One of the things that concerns me, though, is these areas of women's health where the research just isn't happening at the level that it should. And one of the conditions that was brought up in the Q&A is endometriosis, right? And we know that this affects 1 in 10 women. It's a leading cause of infertility, and yet there are no disease-modifying therapies. And the amount of research funding, if you look at even the US NIH, is woefully small. And so just, putting out there, and maybe we can start with you, Miriam. I know it's not in your traditional area that you treat, but like, if you think about a condition like endometriosis, what do you think would be needed to unlock the research and development around that? And then maybe we also have Michael comment on that as well. Let's start with Miriam, please.
I think great question. I think sometimes where we sort of get to a stumbling block, one would say, is we sort of start to narrow down to the minutiae, where we say, okay, why don't we have enough research around endometriosis? I could probably argue and say, 90% of deaths occur, cervical cancer occur in low and middle income countries. There's 0 to 0.5 funding around this. But I think maybe what we could do is really embracing how do we encompass, rather than looking at systems, saying how do we collectively enhance more research around women and the different aspects of along their sort of health journey, whether it's from all the way through almost like a time care from at every stage of life, from birth, adolescence, middle age, postmenopausal. So it's really like, how do we strengthen the entire continuum? And I think how we do that is really building the case around we're missing, I think Michael said 50% of the data. And so any intervention, any strategy that we have is invariably flawed. And so if we say, how do we embrace an encompassing approach to one, not just women and women's health for the sake of the health system and actually to help improve overall outcomes, I think is part of the strategies that one would employ. Of course, we can talk about, innovations or really trying to sort of have that higher level advocacy. But the higher level advocacy really begs us to see the entire system, where we say a win for women is a win for the system and the community. So I think it's really shifting those narratives that'll help to move us forward in terms of getting more research funding. And of course, being deliberately intentional, we're saying this, it's accepting that this cannot continue. And so putting our money where our mouths are, as it were, would go a long way towards sort of shifting narratives around this. Thanks.
Perfect. Michael, anything to add about how we can unlock the mystery of conditions like endometriosis?
Yeah, well, at first, I think if we take a look at endometriosis specifically, let's talk about what it often takes to diagnose it. And it's usually 11 different doctors, or I'm sorry, it's usually 11 years and 8 different doctors to get diagnosed, right? Yet you say 1 in 10 women suffer from endometriosis. One of the things we've done here at McGee is we've set up a multidisciplinary pelvic pain center, which is designed to give that woman that woman-centered care experience, where she goes into that pelvic pain center and we have the psychologist there, we have the endometrial surgeons there, we have the type of people that she would have to be bounced around to over a period of several years, all in one place that can evaluate her immediately and give her answers. And so I think understanding new treatment paradigms that take into consideration the person is critical. But I also think, and I just spoke to a group of VCs right before this call, so it's a very timely question, and understanding that 1 in 10 women get diagnosed with endometriosis, but the actual impact may be much larger than that because of the undiagnosed cases that we talk about, because of the fact that this set of symptoms could lead to a lot of different things. I think it's to teach that VC community the size of the market in women's health. And, there is a significant opportunity in women's health. And I think the dialogue around the President of the United States and ARPA-H and the NIH now around these increased investment in research in women's health will lead to a downstream dialogue in the VC community, because what happens with that money once the investment becomes something that could be a product or could be significant in the marketplace? It needs that follow-on investment. So I'm seeing VC firms coming to the table and trying to get a better understanding of women's health as a field so that they can be prepared to make those investments.
Thanks, Michael. Mahima, did you have something you wanted to add here?
Yeah, I think that endometriosis is similar to other conditions that many other conditions women face that don't get the attention, right? That it needs right now. And I think it requires a couple of things that both of my co-panelists have addressed. I'll just kind of add on to that. One is, when it comes to research, rethinking how we recruit and retain participants. And now there are organizations across the United States that are trying to attract participants in research for endometriosis and diseases like endometriosis in the community. So whether it's going into specific communities where these illnesses are more prevalent, into particular gathering areas where women might be gathering and discussing these issues. So that's one. Second is ensuring that we are attracting and retaining women in leadership positions in medical and clinical research, as well as in health payer organizations, making sure that women have representation, not only as patients, but also as leaders in the field where a lot of decisions are being made about how illnesses are being treated, being addressed, and being paid for and reimbursed. So those are the 2 points that I wanted to add. Thanks, Stephanie.
Great. We are seeing quite a few questions coming in about women's health startups, about getting investment, about how to make sure that we are showing ROI and value-based solutions. And so I think maybe it would be good to kind of wrap some of these together, and maybe start again with you, Mahima. and then comment on that. It's great to see the energy. We need more founders to bring forward these women's health innovations. So how can we show the value?
Yeah, absolutely. So I think Michael touched on this as well, but when we're thinking about showing value, what we have to understand is that for women's health, there is a potential to improve quality of care, empower women, remove access, and all of this ultimately leads to women having healthier days and longer lives. And that translates into dollars for the economy. So when we think about the total addressable market for women's health, it's huge and it's largely untapped. And I think the way in which I would encourage technology startups to think about this is look at the areas that you are investing in and try to make a case for how that's going to impact women being a part of the economy for longer, having healthier days, and being able to participate more fully. Women are the primary decision makers when it comes to economic decision making in the household. And healthier women means that it translates into more purchases into the economy. So the tie-in between women's health and the economy is actually it's a very straight line. So I think that's how we start thinking about it. In terms of where technology is going for women's health, I think the market is really wide open now with generative AI, telemedicine, mobile health applications, and machine learning. I think the potential is tremendous, and being able to show that connection to the total addressable market, I think, is going to be critical.
Great. Michael, anything to add? And also, I know that you are constantly raising funds. So do you have any tips for those that are raising funds and that are working to ensure that VCs do invest in these important innovations?
Yeah, I think Mohima hit it on the head when she talked about the total addressable market, right? There is market opportunity in women's health. We look at women's health as an emerging field, right? Because the value of the fact that this knowledge that we're all of a sudden bringing to the table in droves, and there are data points coming to the table that we've not imagined having before, all of a sudden popping up because we're able to collect it and we're able to refine it and we're able to analyze it so much better now than we were before, and we're concentrating on women's health, right? So this is opening up new market opportunities, and so these total addressable markets are much, much larger than people originally thought. And so I think if you work, in the VC community, they're beginning to be aware of this. So all you startups out there, stay steadfast on solving a problem. If you solve the problem the best way imaginable or the cheapest way imaginable, those are still the best ways to get the attention of the VC. So you continue to go down that path. These market sizes are big and people are starting to know that. So I think you will see the value of your efforts beginning to pay off.
And Miriam, I think one of the really important things in the Lancet Commission reports, the one on women, power, and cancer, and on breast cancer that you worked on, was really the highlighting, bringing visibility to the women. For instance, one of the shocking facts was that we don't actually even know the number of women that are living as survivors of breast cancer, and many facts like that. How have been the discussions that you've seen, whether with private sector investors or with public sector investors, around this economic case for women's health? And do you see things that are coming to light to turn the course on this?
Thanks, Stephanie. And I think in terms of maybe just to piggyback on the tail end of the last comments, is really around sort of looking at the investment and the potential for innovations. And what we've seen definitely is an increasing interest in, as you said, women's health broadly, and looking at how can we design innovations that talk to addressing particular concerns, and how do you get VCs and other people engaged. But I think one of the things that perhaps we need to sort of think through, even as we start to develop all these innovations and additional investment is what is the integration? Sometimes we joke and say Africa is where all pilots come to die, because everybody has this new sort of shiny toy and innovation, but then that doesn't have sustainability. And so looking at, in terms of looking through how do we build sustainable models, yes, the pilot will get you out of the gate, but then how does that then integrate into existing models rather than sort of having a short-term fix that doesn't really speak to the system or doesn't really speak to the needs of women? I think one of the most exciting bits around the increasing interest, Stephanie, has just been the amazing sort of grassroots advocacy that has occurred, and really the need, as Mahima was saying, increasing the visibility, and that has really helped to drive. I mean, we probably have excellent examples from the breast cancer initiatives in the US and stuff, where there's, you know, successful advocacy has ensured that quite a number of funding has been dedicated to this. But we're starting to see grassroots advocacy in different parts of the world, and all really trying to build around that model around how do we increase awareness. And I think the advocacy has also matured. Initially, I would say we all thought of advocacy as sort of holding placards and things, but then really starting to develop these more nuanced models that we've also actually highlighted in the Commission on Breast Cancer, looking at things like legal advocacy. How do we ensure that the legal rights of patients are not infringed as a result of their diagnosis? How do we ensure political advocacy such that we're speaking to policymakers in the language Mahima has described, in the language of economics and savings that we're making? How do we think through community advocacy, where we're actually actively able to mobilize all the stakeholders into shared decision making? And so I think those are part of the trends that we're seeing. Of course, we definitely need a whole lot more, as I said, structured and targeted advocacy to achieve the dream, but I think it is achievable. And I think that's really the goal around how can we work collectively to start to push the needle in this direction.
Great. Yeah, no, thank you. I think this has been a great discussion. I think we've, you know, I feel like we're in an inflection point really for women's health. Because there's really this acknowledgement of the gap and the economic cost of the gap. And there's a discussion about what it takes to fill the gap, right? And what it takes, right, is data, right? And the sex disaggregated data, as many of you mentioned. And the fact that, you know, if we think about it in many ways, and Michael touched on this, women's health is a millennial, right? We've only had the NIH Act that mandated inclusion of women in early stage trials since 1993. And we have a lot of catching up to do, but I think we've named the problem, we've put a value on the problem, and we have some very committed folks that are on this call today and around the world that are working towards that problem. And I think what we've also highlighted on this call is the importance of making sure that we demonstrate and set up the way that we advance these new solutions in a way that demonstrates value tailored towards women who are going to be the end user. And that means keeping the women in mind as we are designing those solutions, and additionally making sure that we are tailoring those solutions to the unique needs that women have. And then I think, Miriam, you just brought up an excellent point, which is about sustainability, right? This isn't about creating pilots, but about truly lasting change that's going to be able to come forward for women. And so, you know, I think with that, I would like to thank all of the panelists. Thank you, Miriam. Thank you, Mahima. Thank you, Michael. Thank you to everyone that's joined. Thank you for everybody that put questions in. We are going to have a write-up of this, and we're going to work on addressing all of those questions. We'll also be involving Indira in that write-up. So we'll make sure to have the patient voice reflected as well. And we hope that you can join us for future Healthcare Transformers webinars. And we hope that you will work alongside us in closing the women's health gaps so that we can bring women-centric solutions and women-centric care to women around the world, so that no matter where a woman lives, It doesn't determine how she lives and if she lives. Thank you.